Hi, everyone, and welcome to our case study of Module 3, the second case study of this module on the relationship between healthcare systems and life expectancy in the US. As you may recall in lesson number 3 of this module, we mentioned that our healthcare systems have enabled the increasing longevity trends. The success of public health initiatives, advancements in medical science, and early interventions have contributed to extending lifespans. And society plays a role here too. Remember, we talked about the social determinants of health in lesson number 2 of this module, and we mentioned education, employment, and social support as good examples for the social determinants of health that ease or exacerbate these healthcare demands. So, population aging affects healthcare systems, but healthcare systems affects longevity and aging trends. And also society plays an important role in the relationship between social attributes of health and population aging and healthcare systems. So we consider reciprocal relationship between all these three components. Now let's move on to discuss the US healthcare systems. The healthcare system in the US is complex and doesn't neatly fit into any single model. It contains elements of all four types, from the Beveridge model, from Bismarck model, from the mixed model, and from the out-of-pocket model. For example, programs like Veterans Health Administration provide care funded by the government, resembling the Beveridge system. At the same time, employer-sponsored health insurance is similar to the Bismarck system. Let's look at the mixed model. The US also has a mixed model in that there are public options like Medicare and Medicaid alongside a vast array of private medical insurance. And lastly, the US is unfortunately also an example of the out-of-pocket model because of a large segment of the population in the US who must pay for healthcare services out of pocket. This is especially true for individuals who do not qualify for public programs and also can't afford private health insurance. So the US healthcare system is often criticized for its complexity, high costs, and the fact that it leaves a significant portion of the population uninsured or underinsured. In this slide, we will focus on the relationship between health expenditure and life expectancy around the world. These two variables, health expenditure and life expectancy, usually exhibit a positive correlation. As you can see in this graph, more spending on healthcare generally leads to higher life expectancy. However, and this is what we want to focus on today, the United States stands as a notable outlier to this trend, prompting us to delve deeper into this discrepancy. Globally, countries that invest more in healthcare often see a corresponding increase in life expectancy. This makes intuitive sense. Look at this graph. More resources often mean better facilities, more healthcare workers, and better access to essential treatments and preventive measures. The result is higher life expectancy. Scandinavian countries like Sweden and Norway, or even Asian nations like Japan and Singapore, have high healthcare expenditure and a corresponding high life expectancy. But the US is an anomaly, high spending, but less impressive outcomes. The United States backs this trend dramatically. Despite spending significantly more per capita on healthcare than any other developed nation, the US lags behind in key indicators of public health, such as life expectancy and infant mortality. Let's try to understand this paradox. Let's zoom in on the paradox of healthcare expenditure in the US to understand its unique position in global healthcare expenditures. So let's start with a staggering figure. Prior to the COVID-19 pandemic, health spending in the United States reached an unprecedented 17% of the country's GDP. This substantially exceeds the average among the OECD countries by a margin of 8 percentage points. In real terms, this means that in 2019, as we saw in the previous graph, each US citizen utilized nearly 11,000 worth of health goods and services. Fast forward to today, healthcare allocation in the US maintains a striking 60% average above its G7 counterparts. So it's worth noting that while Europe and Japan also face aging populations similar to the US, this demographic factor alone does not account for the enormous spending gap. So the question is, where's the money going? So there are many explanations why the health outcomes in the US are quite disappointing compared to other OECD countries, despite the fact that the health expenditure in the US is the highest among OECD countries. One of the explanations, for example, is very high cost of medications. Other explanations are more related to the inefficiencies of the healthcare system. And there are many other explanations. But because in this course we talked about the social determinants of health, we are going to show the explanation by Bradley and Taylor, who focus on the relationship between social expenditure and health outcomes. This study sheds light on a different facet of healthcare. It takes our understanding of health outcomes beyond the confines of hospital walls and medical practices. Do you remember who said that in the long run, housing may be more important to health than hospitals? A compelling insight is that spending on welfare programs seems to be related to health outcomes. So it's not only about hospitals, it's not only about medications or other medical interventions. Bradley and Taylor emphasize the importance on spending on welfare programs as prerequisites for health outcomes. Another finding by these researchers was that overall higher level of social spending are associated with better health outcomes for all OECD countries. But more importantly, it's not only higher levels of social spending, it's also a higher ratio of social to health spending across OECD countries that is associated with health outcomes. Now, let's go back to the case of US, and let's see how Bradley and Taylor explain the weird or the quite bizarre relationship between healthcare expenditure and health outcomes in the US. Before we move on to see what is the health expenditure and the social expenditure in the US, let's define two important terms. Number one is social expenditure. When we say social expenditure, we mean family support, unemployment or housing, as well as programs within those areas with diverse aims, designs, and delivery. And what do we mean by health outcomes? The key indicators for health outcomes are life expectancy, infant mortality, alcohol intake, and smoking prevalence. One of the most important health outcomes is, of course, life expectancy. Now let's move on to rankings on social spending, health spending, and life expectancy in OECD countries, life expectancy as a health outcome. In this table, we have three columns. The first is the percent of social spending as of GDP. The second is the percent of health spending as of GDP. and the last column on the right deals with average life expectancy at birth. And guess what? The US is ranked first in health spending as percent of GDP, 14.4%. However, as we can see on the left side, the social spending as percent of GDP is only 15%. And life expectancy in the US is ranked number 27 with 78.5 years. This gives us an interesting additional data, and as Taylor and Bradley demonstrate, the importance of social spending on health outcomes, on life expectancy. As we can see here, the United States is ranked first in health spending as percent of GDP, however, ranked only 23rd in social spending. Just to conclude this point, so what is Bradley and Taylor showing us, as we saw in the graph? That higher levels of social spending are associated with better health outcomes. And because the US is ranked quite low in social spending, therefore, the health outcomes in the US are quite disappointing.